nagging sense of just being off, where your body just isn't acting like itself. Maybe like unexpected weight gain or strange fat distribution or just this exhaustion you really can't shake.
Yeah, absolutely.
We all deal with stress, obviously. But what if your body's main stress hormone, cortisol, just got stuck in permanent overdrive?
Well, that's exactly what we're diving into today. Welcome, everyone, to our deep dive on Cushing syndrome. It's also known as hypercortisolism.
Hypercortisolism, right.
And it basically means your body tissues are exposed to way too much cortisol or maybe other glucocorticoids.
So our mission today really is to cut through all the complex medical info and give you a clear, a comprehensive understanding of Cushing syndrome.
We'll look at the causes, some might surprise you, and how it shows up across the whole body.
And crucially, how it's diagnosed and how it's managed. We've pulled all this from a major review looking at the pathophysiology, assessment, and care.
Great. So let's start right at the beginning. What is Cushing syndrome, fundamentally? At its core, it's really a collection of symptoms, a whole set of signs and symptoms caused by having too much cortisol floating around in your body. Simple as that, really.
Too much cortisol. Got it. So it's a state of cortisol excess. But I often hear the term Cushing disease. Is that just another name, or is there a difference we should understand?
Good question. That's a really crucial point, actually. Cushing syndrome is the big umbrella term. It covers any situation with excess cortisol.
Any kind, okay.
But Cushing disease, well, that's very specific. It's one type of Cushing syndrome.
Right.
And it's caused by a benign, meaning, non-cancerous tumor on your pituitary gland.
Pituitary gland, okay.
Yeah. And this little tumor, it pumps out too much ACTH, that's the messenger hormone, which then tells your adrenal glands, make more cortisol, over and over. Sometimes pituitary hyperplasia, just too many cells can do it too. And interestingly, women are actually more likely to develop Cushing disease specifically.
Okay, so whether we call it the syndrome, the broad category, or the specific disease of the pituitary, the core issue is this overload of cortisol.
Exactly.
What does that actually do? Like on a basic level, how does it manage to mess with everything?
Well, what's so fascinating and kind of central to this is that cortisol isn't just a stress hormone, it's a really powerful metabolic hormone too.
Okay.
So when you have too much, it literally disrupts, well, almost all your body systems. How you store fat, how you handle sugar, your immune system, even your mood. It's everywhere.
Wow. That sounds incredibly far-reaching. So where does all this extra cortisol actually come from? Is it always something going wrong inside the body?
That's where it gets really eye-opening. And it touches on something many people might actually encounter, maybe without even realizing it. There are two main buckets, exogenous and endogenous.
All tied in inside.
Exactly. Exogenous means from outside the body. And here's the kicker. The most common cause of Cushing syndrome isn't some rare internal thing. It's actually medications.
Medications, really?
Yes. Common glucocorticoid medications, like prednisone, things many people take.
Wow. So people taking these steroids for other health problems could end up with Cushing syndrome as a side effect.
Yeah.
What kinds of conditions are we talking about?
Precisely. These are powerful, often life-saving drugs used for things like asthma, autoimmune disorders like rheumatoid arthritis or lupus, preventing organ rejection after a transplant in some cancer chemotherapies, for really bad allergic reactions, even chronic fibrosis.
So a lot of necessary treatment.
A huge number. So for many people, the symptoms of Cushing syndrome can be this really unfortunate side effect of a treatment they absolutely need.
That's a really important point. Okay, but what about the internal causes, the endogenous ones? If it's not medication, where else can this excess cortisol come from?
Right. So looking inside the body, that pituitary adenoma we just talked about, the one causing Cushing disease by making too much ACTH.
Yeah.
That's actually the most common internal cause, but it's not the only one. Sometimes certain cancers, malignancies, can start producing ACTH-like substances. Think lung cancer, GI tract cancers, pancreatic cancer.
Wow.
Or you could have tumors directly on the adrenal glands themselves, the glands that make cortisol. These can be benign, called adrenal adenomas or cancerous carcinomas.
So the problem could be the pituitary telling the adrenals, or the adrenals themselves going rogue, or even somewhere else entirely.
Exactly. And you can also have something called bilateral adrenal hyperplasia, where both adrenal glands just become enlarged and overactive.
And I saw the sources mentioned there might even be a genetic link sometimes for developing those adrenal tumors.
Yes, research does suggest a genetic component in some cases of adrenocortical tumors. It adds another layer of complexity.
Which kind of leads to this next point.
Yeah.
It sounds like figuring out how common Cushing syndrome actually is must be really tricky.
Oh, incredibly difficult. The true incidence and prevalence are really hard to pin down.
Why is that?
Well, think about it. So many people take prescribed glucocorticoids, right? Their symptoms might just get blamed on the original condition they're being treated for.
Makes sense.
Plus, milder cases might just go undiagnosed. People might feel off, tired, gain some weight, but it gets chalked up to stress or aging. And most cases aren't officially reported in a central registry.
So it's kind of hidden in plain sight sometimes.
Exactly. It's likely far more common than the official numbers suggest, meaning lots of people could be affected without knowing it. Makes awareness really key.
Okay, so we know where the cortisol comes from now.
Yeah.
The really striking part, what does this hormonal overload actually look like? What does it do to someone's body?
Right. Prepare yourself, because the effects are they're widespread and often quite visible.
Okay.
One of the most classic signs is how it changes physical appearance. You get an increase in total body fat, but it gets redistributed in this very characteristic way.
How so?
You often see truncal obesity, so fat gathering around the torso, the abdomen. There's often a buffalo hump, which is a fat pad on the upper back, neck, shoulders area.
Right, I've heard that.
And the face tends to get rounder, puffier. We call it a moon face.
Moon face, buffalo hump, truncal obesity. Very distinctive.
Very. And what makes it even more noticeable is that often the arms and legs actually become thinner, sort of contrasting with the central weight gain.
Like the body is just completely reshaping itself.
Yeah.
What about the skin? You mentioned fragile capillaries earlier.
Yeah, the skin takes a real hit. It becomes noticeably thin, almost papery, and very fragile. Capillaries break easily, leading to lots of bruising. And you might see these reddish-purple stretch marks. They're called striae, typically on the abdomen, maybe thighs, upper arms.
Why does that happen?
It's because cortisol actually has a destructive effect on collagen. Collagen gives skin its structure and elasticity. So without it, the skin weakens, stretches, and doesn't heal well either. Wound healing can be really slow.
Okay. And does it affect hair too?
It can, yes. Acne is pretty common. And something called hirsutism.
Which is?
Increased body hair growth. Sometimes a fine coating of hair on the face and body. But paradoxically, women might also experience male pattern balding, and occasionally clitoral hypertrophy can occur too.
So lots of visible physical changes.
Yeah.
But what about internally? What's happening to muscles and bones?
Big impact there too. In the musculoskeletal system, you see a definite decrease in muscle mass and strength, especially arms and legs.
Why?
Because cortisol breaks down tissue protein for energy, so muscle wasting occurs, and then there's the bone issue. Serious bone density loss is a major problem.
Leading to osteoporosis.
Exactly. Osteoporosis is common, which means a much higher risk for fragility fractures, bones breaking from minimal stress, people can lose height, vertebrae can collapse, and sometimes you even see aseptic necrosis of the head of the femur where the bone tissue dies off. It's rough on the skeleton.
Wow. Okay, beyond structure. The immune system. This fascinates me. How does all that cortisol affect our body's defenses?
Yeah, this is critical. Think of cortisol as putting the brakes on the immune system. Too much cortisol reduces the production of lymphocytes, key immune cells.
Okay.
It actually shrinks the organs where lymphocytes hang out, like the spleen and lymph nodes, and it dampens the production of cytokines, which are like the communication signals for the immune system.
So basically, it weakens the immune response.
Significantly, which means, yes, an increased risk for getting infections. But here's the really tricky part, the kicker.
What was that?
It also masks the typical signs of an infection because cortisol suppresses inflammation. So someone could have a serious infection brewing, but they might not get a fever, they might not have the usual redness or swelling or pus formation.
That's dangerous. It hides the problem.
Extremely dangerous. It makes diagnosis much harder.
Okay, what about fluid balance? How does that get affected? And what does it mean for the heart?
Right, cortisol makes your kidneys hold on to sodium and water, so you reabsorb and retain them.
Leading to
Fluid overload, hypervolemia, and that shows up as edema swelling, usually in the legs and feet, but it can be more widespread.
and heart.
Well, all that extra fluid volume increases blood pressure, often significantly, and you might feel a full bounding pulse. It puts a strain on the cardiovascular system.
And sugar. How does it mess with blood glucose?
Glucose metabolism gets really thrown off kilter. Your fasting blood sugar levels tend to go up.
Why?
2 reasons, mainly. The liver starts putting out more glucose, and at the same time, your body's cells become less sensitive to insulin resistance.
So glucose can't get into the cells easily.
Exactly. It struggles to get into the tissues where it's needed for energy. It's almost like developing a form of diabetes, sometimes called steroid-induced diabetes.
Okay. And specifically for women, you mentioned Cushing disease is more common. Are there direct reproductive system impacts from the cortisol excess itself?
Yes. The high cortisol levels often come with increased androgens, male-type hormones that women also have in small amounts.
Right.
And these elevated androgens disrupt the normal feedback loops controlling ovarian hormones like estrogen and progesterone.
So what happens then?
It often leads to oligomenorrhea, which means scant or infrequent menstrual periods, or sometimes periods might stop altogether.
Even the digestive system takes a hit, I read.
It certainly can. Cortisol increases the secretion of hydrochloric acid in the stomach, and at the same time, it decreases the production of the protective mucus lining. So more acid, less protection.
Recipe for ulcers?
Exactly. Patients become much more prone to developing peptic ulcers.
Goodness. Okay, we've covered a lot of physical effects, but I can only imagine what this does to someone mentally, emotionally. What's the psychosocial impact like?
It's often described as one of the hardest parts of the condition. It's really profound. Emotional instability is extremely common.
Like mood swings?
Severe mood swings, yeah. Irritability, anxiety, sometimes new onset confusion, especially in older adults. Depression is very common.
That sounds incredibly difficult.
It is. Patients often report just not feeling like themselves anymore. They might cry or laugh inappropriately, have real trouble concentrating, major sleep problems, insomnia, or waking up frequently, and just profound debilitating fatigue that isn't relieved by rest.
Why does it affect mood and cognition so much?
Well, the excess hormones seem to actually heighten awareness and responses to sensory input. Everything feels amplified, overwhelming. It's like the brain's emotional thermostat is broken.
Wow. Okay. So given this huge range of effects, some visible, some hidden, some physical, some mental, how do doctors actually figure this out? How do they diagnose Cushing syndrome?
It's definitely a process. It usually starts with a really detailed assessment history.
Asking about
all the things we've just discussed, really. Asking you, the patient, about unexplained weight gain, especially that central pattern, increased appetite, changes in sleep or activity levels, that persistent fatigue or muscle weakness, any bone pain or fractures that seem too easy.
frequent infections, bruising easily.
Exactly. For women, changes in menstrual cycles, any new stomach problems like heartburn or pain suggesting an ulcer. We cast a wide net based on the symptoms.
And then the physical exam would look for those classic signs.
Precisely. During the physical assessment, we're specifically looking for those cues. The moon face, the buffalo hump, truncal obesity, maybe those thin arms and legs, checking blood pressure for hypertension, looking for edema, checking the skin for thinness, bruising, those striae, assessing muscle strength, looking for signs of reduced immunity, increased hair growth. It forms a very distinctive clinical picture when present.
Okay, history and physical exam point towards it. What about lab tests?
Labs are crucial for confirmation. The first step is proving there's too much cortisol. So we measure cortisol levels in blood, saliva, and urine. They'll typically be consistently high in Cushing syndrome.
Blood, saliva, urine.
Okay. Then plasma ACTH levels become really important. That's the pituitary hormone. Measuring ACTH helps figure out the cause.
How so?
Well, if ACTH is high, it points towards the pituitary gland being the problem, likely Cushing disease. The pituitary is overworking.
Makes sense.
But if ACTH is low or suppressed, it suggests the problem is either directly in the adrenal glands themselves, churning out cortisol independently, or it's caused by taking external steroids, which would shut down the body's own ACTH production.
Okay, that difference is key. You mentioned saliva and urine tests too.
Yes. Salivary cortisol, especially samples taken late at night, are really useful. Cortisol levels should naturally be lowest then, so a high late-night salivary cortisol is a strong indicator. It reflects blood levels pretty accurately.
And urine?
A 24-hour urine collection for cortisol is a very common test. It measures the total amount of cortisol excreted over a full day, giving a good average picture rather than just a snapshot like a single blood test. Again, levels would be elevated.
Are there other screening tests? I think I read about one involving dexamethasone.
Yes, the dexamethasone suppression test. It's often used for screening. The overnight version is common. You take a dose of dexamethasone, which is a synthetic steroid, at bedtime.
Okay.
Then your cortisol level is measured the next morning. In a healthy person, the dexamethasone should suppress the body's own cortisol production. If your cortisol levels aren't suppressed, it suggests the feedback system is broken, which is characteristic of Cushing syndrome.
Got it. Any other lab findings that often pop up?
Yeah, you often see other changes like increased blood glucose levels, a decreased lymphocyte count in the white blood cells, maybe increased sodium and decreased serum calcium levels. They all fit the picture.
So once the labs confirm hypercortisolism, then you look for the source with imaging.
Exactly. Yeah. And this is a really vital point. Imaging like CT or MRI scans comes after the biochemical diagnosis of cortisol excess is confirmed.
Why is that sequence so important? Why not scan earlier?
Great question. It's absolutely critical to avoid misdiagnosis. You could do a scan for some other reason and find a small, non-functioning nodule on the pituitary or adrenal gland. These are actually quite common. Incidentalomas.
Something that looks like a tumor but isn't actually causing the problem.
Precisely. If you haven't confirmed hypercortisolism first, finding one of those could send everyone down the wrong path, leading to unnecessary anxiety, more tests, maybe even inappropriate treatment.
So confirm the hormone problem first, then image to find the culprit.
Exactly. We use MRI typically for the pituitary gland and CT or MRI for the adrenal gland, but only once we know for sure that excess cortisol is the issue we need to track down.
Okay, makes perfect sense. So once Cushing syndrome is diagnosed and maybe the cause is found, what's the plan? How do you manage this cortisol overload?
Right. Management really focuses on tackling the biggest problems the patient is facing. Based on our source material, the priorities are typically dealing with the fluid overload, preventing potential injuries, and reducing the risk of infection.
Fluid, injury, infection.
Okay. The main goals overall are obviously to get those plasma cortisol levels down. If there's a tumor, the goal is to remove it, and ultimately to help restore a more normal or at least acceptable body appearance and function.
Is a cure possible?
The good news is, yes, when it's caused by a specific pituitary or adrenal problem that can be surgically removed, a cure is definitely possible. If it's drug-induced, the focus is more on managing the symptoms, preventing complications, and maybe carefully adjusting the positive medication if feasible.
Okay, let's break down the management. That fluid overload sounds serious. How do you tackle that first?
Patient safety is absolutely number one there. We have to prevent that fluid overload from getting worse and leading to really dangerous things like pulmonary edema fluid backing up in the lungs or even heart failure.
So lots of monitoring.
Constant monitoring. Checking for signs like a bounding pulse, neck veins sticking out, that's jugular venous distension, listening to the lungs for crackles, watching for increasing edema, tracking urine output very closely, maybe every couple of hours in acute situations.
And the skin must be at risk with all that swelling.
Definitely. Edema to skin is fragile and prone to breaking down. So things like using a pressure-reducing mattress, turning the patient regularly, checking pressure points are all really important parts of care.
What about medications to directly lower cortisol?
Yes. Drug therapy is a key part of non-surgical management. There are medications called steroidogenesis inhibitors.
Meaning they stop steroid production.
Exactly. They inhibit the body's ability to synthesize cortisol. Drugs like ketoconazole or levoketoconazole fall into this category.
Anything important to know about those?
Yes. A really important drug alert for ketoconazole. It's teratogenic, can cause birth defects. So any patient who is pregnant or planning pregnancy needs to tell their provider immediately if they're prescribed it.
Good to know. Other drugs?
There are also drugs that target excess ACTH production from the pituitary, like cyproheptadine or mifepristone, which is sometimes used, especially if the patient also has type 2 diabetes that's not responding well. And newer agents like osilodrostat or pasireotide specifically target pituitary adenomas.
And nutrition plays a role in fluid management too.
Absolutely. Fluid restriction and sodium restriction are usually necessary. It involves teaching patients how to really read food labels carefully to track their intake.
How do you know if all this is working? What's the best way to track fluid?
You know, it sounds simple, but the source material really emphasizes daily weight monitoring. It's considered the single best indicator of fluid retention and overload.
Really?
So,
just stepping on the scale?
Yep. A gain of even 1 pound can represent about 500 milliliters of retained fluid. So weighing at the same time each day with the same amount of clothing gives a really accurate picture for both the clinical team and for the patient managing at home. Tracking intake and output is important too, of course.
Okay. What if non-surgical approaches aren't enough? Or if there's a clear tumor? What about surgery?
Surgery is often the definitive treatment if the cause is a pituitary adenoma or an adrenal tumor. The main surgical approaches are removing the pituitary adenoma, that's called a hypophysectomy, or removing one or both adrenal glands and adrenalectomy.
Is that major surgery?
It can be, but increasingly adrenalectomy is done laparoscopically, minimally invasive, with smaller incisions, which usually means a quicker recovery. Hypophysectomy is typically done transpenoidally through the nose.
What needs to happen before surgery?
Pre-op care is absolutely vital. We need to get the patient as stable as possible. That means correcting fluid and electrolyte imbalances, especially potassium, sodium, chloride, getting blood sugar under control, taking steps to prevent infections, and reducing fall risk because of the muscle weakness. And a really crucial step, patients are given glucocorticoids, steroids, before and during the surgery.
Why? If the problem is too much cortisol?
Because removing the source of the excess cortisol, the tumor causes a sudden dramatic drop in cortisol levels. The body has adapted to the high levels, and the normal feedback systems are suppressed. Without giving replacement steroids temporarily, the patient could go into an acute adrenal crisis, which is life-threatening shock.
Okay, that makes sense. What about after the surgery?
Post-op, patients are usually monitored very closely, often in an ICU setting initially. We're watching carefully for signs of shock, checking vital signs frequently, maybe every 15 minutes right after surgery.
And hormone replacement?
That depends. If both adrenal glands were removed, bilateral adrenalectomy, then yes, the patient needs lifelong hormone replacement therapy. Absolutely essential because their body can no longer make cortisol or other vital adrenal hormones.
Lifelong, wow.
Yes, if only one adrenal gland was removed, unilateral, the other gland usually recovers function over time, but the patient might still need HRT for weeks, months, or even up to 2 years, gradually tapering off as the remaining gland kicks back in.
So even after treatment, whether it's medication or surgery, it sounds like some risks continue for a while, like injury risk.
Absolutely. Preventing injury remains a big focus during recovery. The skin, for example, stays fragile for weeks or months.
So patients still need to be careful.
Very careful. Avoid any trauma to the skin. Use a soft toothbrush, an electric shaver instead of a razor. Keep skin clean and dry, maybe use lotion. Apply gentle pressure for longer after blood draws to prevent big bruises.
And the bones.
The bones also take a long time to recover strength. Fragility fractures are still a risk for months, potentially years. So things like using lift sheets to move the patient in bed, assisting them carefully when they walk, maybe using walkers or canes, a gait belt, all important to prevent falls and fractures.
Does nutrition help with bone recovery?
Yes, diet is important here too. A diet high in calories and protein helps with tissue rebuilding. And specifically for bones, ensuring adequate calcium and vitamin D is key. Good sources are milk, cheese, yogurt, green leafy vegetables, root vegetables.
Anything to avoid?
Yeah, caffeine and alcohol are generally advised against. They can irritate the stomach, increasing that ulcer risk we talked about, and alcohol can also negatively impact bone density.
Right, the GI bleeding risk, that continues after treatment too.
It can, especially while cortisol levels are still normalizing or if the patient is on steroid replacement. Remember, cortisol reduces that protective mucus, decreases blood flow to the stomach lining, and increases acid.
So still need to be cautious.
Yes. Often patients will continue on medications like antacids, H2 blockers like famotidine, or proton pump inhibitors like omeprazole for a while, and they should definitely continue to avoid things that irritate the stomach. Alcohol, caffeine, smoking, fasting for long periods, and NSAIDs like ibuprofen or aspirin.
Okay, and the third big risk, infection. How is that managed long term?
Infection prevention remains critical, especially for patients recovering from surgery or those on lifelong hormone replacement, as their immune system might still be somewhat compromised or behaving differently.
So basic hygiene is extra important.
Absolutely paramount. Strict hand washing, maybe visitors wearing masks if they have a cold, using aseptic technique for any wound care or procedures.
And watching for signs of infection.
Constantly assessing, and remembering that the usual signs might be masked. A low-grade fever might be the only sign. No obvious pus or redness doesn't mean no infection.
So what do you monitor?
We monitor the complete blood count, check their mouth for thrush, listen to their lungs, check urine for signs of UTI, and track vital signs closely. Even a small temperature rise, like 1 degree Fahrenheit or half a degree Celsius, could be significant and needs investigation.
Any other preventive measures?
Simple things like pulmonary hygiene, encouraging deep breathing, maybe using an incentive spirometer, especially after surgery, can help prevent pneumonia.
Okay, so managing the transition home and long-term self-care sounds really crucial. What do patients need to focus on once they leave the hospital or finish initial treatment?
Yeah, living with this long-term relies heavily on good self-management. One thing is that muscle weakness and fatigue can linger for weeks, even months after treatment starts working, which means the risk of falls remains high for a while. Patients might need some temporary adjustments at home, like living on one floor, or maybe needing a home health aide for a period. Safety first.
And that daily weight monitoring you mentioned, does that continue at home?
Oh, absolutely. It's a vital part of home care. Patients and their families are taught to weigh daily, same time, same scale, same clothes.
And report changes.
Yes, they need clear instructions on when to call their doctor or nurse. Typically, reporting a weight gain of more than, say, 3 pounds in a week, or maybe 1 to 2 pounds literally overnight, because that signals fluid retention is becoming a problem again.
And for those folks who had both adrenals removed that lifelong hormone replacement, what's key there?
Honestly, the word lifelong is key. And understanding it's absolutely life-sustaining, their body cannot make cortisol anymore.
So skipping doses is a huge no-no.
A massive no-no. Stopping the medication, even for just a day or two, can trigger acute adrenal insufficiency. That's a medical emergency, potentially fatal. It cannot be stressed enough.
Wow, okay. And infection prevention at home? Same principles?
Yep, meticulous hygiene. Avoiding crowds or people who are obviously sick, especially during flu season. Getting their annual flu shot is very important. And knowing to call their provider right away if they get a fever or any sign of infection, however minor it seems, because of that masked response possibility.
Okay, for the cortisol replacement therapy itself, what specific instructions do patients need? This sounds like something they really need to master.
Absolutely, there are several key points. First, usually take the medication in divided doses, maybe 2/3 in the morning and 1/3 in the early afternoon, to mimic the body's natural rhythm. And always take it with food or a snack to reduce stomach upset.
Okay, what about stress?
Crucial point. They need to learn to increase their dosage during times of significant physical or emotional stress. Things like having surgery, running a fever, experiencing trauma, even major life events. The body needs more cortisol then, and since they can't make it, they need to take extra. Their doctor will give them specific stress dosing rules.
Never skip a dose, we covered that. What if they're sick, like vomiting?
If they have persistent vomiting or diarrhea and physically can't keep the oral medication down for, say, 24 to 36 hours, they need to go to the ER, period. They might need intravenous steroids.
Okay.
They should also always wear a medical alert bracelet or necklace that clearly states they have adrenal insufficiency and are steroid dependent.
Makes sense.
Regular follow-up appointments are essential for monitoring and dose adjustments. And finally, many patients are taught how to give themselves an emergency injection of hydrocortisone intramuscularly, just in case they can't take their pills and can't get immediate medical help. It's a safety net.
Right, wow. So let's try and wrap this up. What does all this really mean for us? We've gone through the whole journey, understanding cortisol excess, the surprising ways it comes about, like from common meds.
Yeah, and how it affects literally every part of the body, physically and mentally.
And then the complex ways it's diagnosed and managed, including surgery, and that critical lifelong care for some. It really touches every aspect of life.
It absolutely does. I think the big picture takeaway here is just how profoundly interconnected our endocrine system is with everything else. Cortisol in particular really illustrates this.
How so?
It shows how this one hormone influences our appearance, our strength, our immune defenses, our metabolism, our mood. It's a master regulator, and when it goes out of balance, like in Cushing syndrome, the effects ripple outwards systemically.
Yeah, it's a powerful reminder of that balance. Which leaves us with maybe a final thought to chew on. Consider how vital this hormonal balance is for just, well, feeling normal, feeling healthy, and how things we might see as minor shifts or even necessary medical treatments can cascade into these huge, widespread, very visible changes. So maybe the question is, in our modern world, with increasing environmental stressors, complex medications, how might our understanding of the body's stress response and its potential to go wrong become even more critical? Not just for treating diseases like Cushing's, but for proactive health management, for recognizing early signs when maybe our internal balance is starting to tip.